Hello and welcome back to another episode of Taking Control of Cancer, the podcast brought to you by the North East London Cancer Alliance. I'm Steve Bland, and think of this podcast as a bit of a how-to guide to help you overcome common myths, fears and barriers to cancer prevention, diagnosis, treatment and care. In this series, we try and give both patients and healthcare professionals tangible things that they and you can do when it comes to cancer, because while we know that not all cancers are preventable, there are things that we could all do to make a real positive difference to our own health, our own well-being, but also the health and well-being of our family, our friends and our colleagues. If you heard our episodes from the Harrogate UK Oncology Forum recently, we touched on some of the uses of AI and how AI is being used increasingly in all different ways. And this episode is all about AI, but it's all about one particular area that's being used. So without further ado, let's get stuck into it. So to talk about AI and chest x-rays, I've got three guests. Oliver Hawkins, you're the Senior Project Manager at the North East London Cancer Alliance. Hello.
Hello.
Angela Wong, you're back. You're Chief Medical Officer for the North East London Cancer Alliance.
Hello again.
And we have Basab Bhattacharya. Have I said your name right, Bash? Yeah. Well, I do. Consultant radiologist, and you've got an interest in body imaging, clinical informatics and AI. And you work at the Barking, Havering and Redbridge University Hospitals NHS Trust. Right, so who wants to explain this, your chest x-ray? Or I guess kind of what's the challenge that AI is solving when it comes to chest x-rays?
Shall I start with a case for change?
Yeah.
So we know from Health Education England data, we don't have enough diagnosticians within the cancer workforce, and this is particularly marked in radiology. So we don't have enough radiologists and radiographers both to undertake scans and report them. So we have this reporting gap. And what has happened over time is that our radiology colleagues are focusing more on the complex scans, the CT scans and the MRI scans within their job plans. And what has happened is the plain films, which is a significant volume of scans, of x-rays, are creating a significant backlog because we don't have that reporting capacity. Yeah. And one of the reasons that we were interested in this is because artificial intelligence reporting for chest x-rays can do that pre-read, and it can also increase the safety of this particular imaging pathway, because we, through our prioritisation of when these need to be reported by a human, will, if you like, immediately identify those that need to be reported in 24 hours or that need action within 48 to 72 hours, and the normal scan. So I think it's helping us through that pre-read to increase the safety by pulling forward patients for reporting, but also for and identifying patients who need to go on to have a CT scan, but also what we're hoping for is a productivity gain in the normal films, where we can perhaps read them faster because we've had a pre-read that says they're normal. And what's been really exciting about this project is that we have been able to implement this across the whole of North East London, so that equity of access and implementation has been really important.
So Bash and Oliver, what are your roles in the project?
So I'm a consultant radiologist specialising in body imaging. I'm also a clinical informatics lead for AI for my trust as well. So I've previously was CD radiology for my department as well, and I've got background interest in oncological imaging. And so I've played roles in setting up different AI projects, not to do with cancer, but things like the Brainomics, in a stroke detection one, looking at AI to help with emergency imaging, such as the ADOC cross-sectional imaging one. And so I got involved because it sort of merges my interest, because what I found with a lot of these tech projects, it's important to have appropriate clinical leadership to push things through. And one of the things that I have seen is that there have been issues where it's not just detecting the abnormality, it's making sure the abnormality is been in the appropriate workflow. There's zero point in having an abnormality detected at some point when it's not put into the actual workflow. So I think the AI role to try and get that compressed, so an abnormality is detected and then it's then put in the appropriate workflow, that's actually almost as relevant as the detection level. Also,
with that being a human bit.
That's a human bit.
Yeah.
A lot of AI, main problems with AI is a human bit, not the AI.
Yeah. And Ollie, where's your role in this?
So I am I've been project managing the AI project for quite a while now. So it started back into 2023, and it was sort of a thought exercise of Basab's. We wanted to look at a chest X-ray or a chest X-ray solution, an AI solution for. We were coming at it from a sort of lung cancer angle and looking how we could optimize the lung cancer pathway. Specifically delivering a CT within a day or 3 days of a patient having had an abnormal chest X-ray. So that was the angle we were coming in at, but there's a whole host of other benefits and ancillary benefits associated with it. So I've been managing the project from business case, procurement, award, and technical integration as well. So that's liaising with all three trusts, looking at how we technically integrate the solution into the clinical infrastructure, undertaking the information governance exercises, and also the coordinating the clinical safety exercise as well.
I imagine I did a podcast a number of years back, and I can remember someone saying in one hospital there was something like 200 different computer systems. You know, how challenging has it been to actually implement the technology into existing patchwork technology systems in hospitals?
So there is some variation in North East London. We all use the same PACS, although it's all on-premises server-based PACS, and that's important because if it's in a cloud infrastructure, and that is the future, we are moving from PACS. PACS is a picture archive and communication system. That's the radiology platform that consultants use to upload, look at images and store them securely. We are moving from a on-premises system to a cloud-based system. So in the future, these kind of integrations will be much more streamlined. It doesn't require a lot of hands-on ICT, that's IT development work on site, so it becomes a lot easier. We're relatively in a good place in terms of other networks who have dozens of different systems. We do have different radiology information systems, but one of the principal benefits in fact, it was one of the key criteria that we were looking at when we were assessing the different AI products, is that they need to be available on a marketplace for different AI solutions, which is held centrally by a company called Sectra, who provides our radiology systems. And that's important because it means the integration is much more streamlined. We don't have to do a separate DPIA, that's the information governance process. So it all becomes much more streamlined if we go through. So we were thinking about that, from the offset. How do we make this much more streamlined, giving our different variations in clinical and other IT infrastructure?
So Bash, you've kind of touched on it, and Angela touched on it. Let's just outline kind of what the real benefit is for patients of reducing the wait time for these chest X-ray results.
I think one of the issues has been, so let's just break it down. So let's just say you're a GP. You have a patient comes into that GP practice, and they want a chest X-ray. Traditional pathway, they'd send a paper request or electronic request, recently be paper request, it goes in. It then get vetted or whatever, probably just auto vetted, then the patient would come in at some point and have their chest X-ray. That chest X-ray would then go onto a reporting pile, probably, and that could be routine, urgent, 2-week wait. If it's not 2-week wait, e.g. they've got a cancer type symptom, it'd be routine, and that could take, back in the day, 4 to 6 weeks before anyone would lay an eye on it. So you could have a patient who's got a time bomb in their chest and no one's looking at it. With the AI, that should identify, one common analogy is a needle in a haystack. You can then have a better chance to look at that needle. But is it a needle? Then we've got issues about the AI. Then what can happen is that can be prioritised by a trained professional, and then be expedited into the pathway. Like if there's an obvious lesion that's been there, we're worried about, then they can get a CT, hopefully expedite that, and once CT's been done, it can go down the pathway. Because with some cancers, because the main thing is lung cancer. Lung cancer is one of those cancers that, if it's caught early, it can be dealt with quite relatively easily. But if it goes too far, people can't be treated. So that's the actual role of it. And there's other ancillary benefits, because this AI, one thing we looked at with AI was looking at things other than cancer, like one thing we looked at is things like nasogastric tube, because that's a never event. Nasogastric tube goes down instead of the esophagus, goes down the airways. That's a disaster. I've seen that happen several times. That's a never event. And these things, and because we're doing so much more imaging and the training isn't quite there where we want it, big for juniors because there's so much to learn, those are other ancillary benefits that an AI could possibly do to help that.
And because the x-rays are being reported in real time, it's almost agnostic to the route of referral. So you might get a GP referral that's an urgent suspected cancer, but somebody who's referred routinely, and it could be the person who's referred routinely that has the cancer. And so what this will do in the real-time reporting that happens, it will flag the patients to be then read by a human. That's our safety element of it. So if you like, pulling that patient through the pathway so that they're expedited for reporting. Because previously, as I've mentioned about backlogs, we would report chronologically, and that doesn't match, if you like, what's on the x-ray, whereas now we're reporting according to a pre-triage of what is on the x-ray.
That's so interesting. Bash, you mentioned, though, a few times when you were explaining the process, you mentioned a few human bits of it as well. How reliant is the AI on those human bits?
AI is fundamentally reliant on the pre-test probability, and you see that a lot, because remember, so although AI itself is very good, it has significant limitations. So the AI will really look at the AI we've got will really look at one modality, X-ray, at one time. So there could be an abnormality on the X-ray that's been there before. There's an abnormality that could have been seen on the CT, but it can't look at that. There's also, it depends on what the human itself looks at and what they think. Also, it looks at the workflow is very important. So you could have a chest X-ray. If you've got an optimized workflow, a chest X-ray can maybe take about several minutes to report. If you then throw in something new to it that person's not used to, that can then add on about 30 seconds, which doesn't sound a lot, but percentage-wise is a lot. So you've then got to train people, make sure they know what it is. Some people maybe, you've got things like, once again, automation bias. The computer says no, computer says yes. How do they use it? So there's lots of that. The human aspect of it is actually more important than the actual AI bit, because that's quite mechanistic, if you see what I mean.
Yeah, no, I do, and I guess it is another benefit I possibly haven't mentioned. You're going to get people who don't have cancer that are going to get the good news quicker as well. Is that?
Yeah. That would also be the aim. But I think one of the challenges is, and why we have to work, if you like, very closely with the operational teams in supporting that reporting capacity, is that there may be a tendency, because we're focusing on the abnormal and we're not reporting chronologically, that the normals, if they're in a backlog, might take a little bit longer. So I think we need to work in that increased productivity, because if you like, the pre-read has said it's normal, so that we can report more faster, hand in glove with that, so that we can ensure that the patients have a normal X-ray are also reassured quickly.
What have been the big challenges then with this? Ollie, you touched on a couple at the start, but what have been the big challenges, from all your perspectives with this project?
It was procurement, if I'm honest, because one thing that this entire project has been good for is trying to optimise the procurement pathways, because my trust, North East London is a very busy area. We've got lots of patients with different needs, and we don't have enough people. I remember looking at the number of radiologists per parts of London, and I think if you compared us to North West London, we effectively had a third less per 100,000 patients for radiologists. And so it's a lot of work, and trying to get people to organise out for that. For example, my trust was on Opal 4, which is like to have to put their into getting clinical work quite a lot. So it's trying to organise these pathways where we can just sit down and procure things, because that was actually the biggest thing, because I think actually this project actually kicked off in 2022 tail end, because I think and so it takes ages getting everybody in the room, getting everybody to agree, then you've got to go for procurement, then you've got to do the individual DPIAs, which is information governance. A lot of the main issue is, once again, human processes.
And do you have some skepticism when it comes to the use of AI? Are some people less kind of receptive to maybe using it more?
I mean, it's early days. I think there have been mixed results from our use case. We went live with the AI at Barts Health, and we had to turn it off to ED at the Whips Cross site because it was causing a lot of doctors were responding to it and not fully understanding what the difference between an AI prioritization was and an actual formal read, and so we had to scale it back. But that was an opportunity for learning, and we took that away, and we developed, SOPs and protocols and training. We took it through every possible governance process there is, and we're now starting to stagger back the rollout of ED. So we've followed this process and just recently gone live with the ED at BHRUT, and that's been going well. I think the other big challenges for me, Basab's touched on procurement. It was quite a drawn-out process. We did have some challenges from some disgruntled suppliers who weren't successful, and that caused the delay.
Yeah,
but for
let's
me,
go over that.
Yeah, but for me, the big thing was about the technical integration and not fully appreciating just how much time we would need from people in the PACS department or the IT departments or from the information governance or clinical safety. Clinical safety is a huge aspect of this because the AI is considered a medical device, a software medical device. And so in order to use it in a clinical setting, you have to do a clinical safety exercise, and that requires meeting with we did that as it took a uniform approach to that. So we had the clinical teams in the room. We went through all the possible hazards, all the possible risks. We talked them through.
Which includes the unintended consequences.
Yeah. Yeah, and we created mitigation plans for those, and then had to get that signed off through each trust's respective clinical informatics and clinical safety boards, and that was a process we couldn't get around, which we had to do, which was and important to do. But yeah, it was it's a lot of resource and a lot of time.
What are the risks then in this kind of project and this kind of use of AI? And in terms of the patients, was there any reassurance you had to do with the patients to say this is actually safe, this is reliable, you trust us on this?
I think the main thing to realise that with this, the AI is basically just an alert. Everything still gets reported by a human. The main responsibility is still human. So nothing is independent. It is fundamentally a prioritisation tool. Downstream, could there be issues where there is some evidence here that if an AI read of a normal, low-risk chest X-ray is negative, once again, I should point out, just because a chest X-ray is normal doesn't mean they don't have a cancer. So you can't say someone doesn't have cancer, but because it can miss up to 13% cancer, but it depends upon the risk probability of that patient. So you have to be careful from that perspective.
I think it's safer in imaging because of IRMA regulation, which essentially means that if you've exposed a patient to ionising radiation, you have a legal obligation to report that. So unlike AI potentially in other medical fields, this has to have a human read, which it brings in the safety. But just coming back to your point about potential risks, one of the things that has been set is a high sensitivity, so it's pulling through the true positives. A potential risk from that's been worked through the hazard log is that, does that mean, if you like, if AI has overcalled, that potentially a patient could end up with more CT scans as a consequence? And obviously we're going through that evaluation, but I think the counter to that is it's overcalled, it's reported by a radiologist who has had training, and this is a secondary capture, so it's a triage to say, look, it might be this, but the final report is issued by a radiologist.
So how will this project develop, and I guess how will AI develop in looking at chest X-rays specifically? How will it develop in the next year, the next 5 years?
It really depends, but I think it'll be multifocal. So with the confines of this, what we hope it'll do is mean that people will fundamentally get their chest X-ray, get it looked at, and if it's got an abnormality in, then be reviewed and potentially have their CT and then basically push down the cancer by pathway, or say if that be a hard way, that will take time to evaluate, and I think that will quite a lot of evidence. Other ways that can be done would be like, can we establish that an imaging negative we don't do anything about? Because if that is done, then that actually has significant resource implications, because we do huge amounts of chest X-ray. And if I'm honest, although Andrew said that everything has to have a chest X-ray, has to report, I suspect there's some parts of the country where that's only honoured in very limited measure, where X-ray reports are only given if people specifically ask for it, if you see what I mean. So there's a lot of areas in which there are not enough people to read the X-ray where this can be beneficial, and then you can think about, if we can do it in this area, can we then do it in other areas? Because radiology inflation, the amount of scans per patient, has gone through the roof. So if this can even do that bit, that has massive implications not only for cancer, but diagnostics as a whole.
You mentioned other parts of the country where else is work going on in AI, and are we kind of like leading the way in North East London? Where what's going on in other parts of the UK?
We aspire to be leaders in AI in everything we do. I think we were one of 11 or 12 networks nationally to be selected for an in-service valuation. So this is an NHS England program, and that we're part of. We're also looking at different AI solutions currently for the CT aspect of the pathway, looking at nodule follow-up. The sky's the limit really into the different solutions. We're also looking at an AI chatbot to streamline the front end of the pathway, supporting patients in how they engage with the hospital, helping them manage their appointments, improving their experience in the front end, because there's a lot of value to be added in streamlining and improving the patient experience of just getting into the hospital and having their diagnostic and managing their appointments, and just providing some early guidance.
I mean, yeah, let's expand the conversation then to different uses of AI potentially and in areas, because it's, we all know, anybody listening, everyone in the room here, we see AI in every single aspect of life, don't we, Angela? You were saying about booking a holiday, via AI. So where else could we use it, and where maybe shouldn't we use it?
So I think that this reflection, describing at home how you can actually go onto a chatbot if it's anything financial with your bank or in retail, why can't we do that the same for our cancer pathways? And one of the projects that we're doing is looking at conversational AI. So, for example, if you're a colorectal cancer patient and you need to have a colonoscopy, from the first point of being referred from your GP, this is currently a pilot that we're doing at the moment, to if you like, guide and support a patient to come through that entire diagnostic pathway, particularly, for example, if you're taking bowel prep at 10 o'clock at night, you can go on your chatbot for your retail and for your banking, but, who can you ask? And so we're developing a sort of suite of responses to support a patient and through their pathway in eventuality, perhaps to support attendance, sort of reducing DNA rates. And if somebody really can't attend, to perhaps be able to go in without making phone calls to cancel an appointment, rebook, and to offer that appointment to somebody else. So that's an example of where we're looking at conversational AI to support patient experience through cancer pathways.
I can also give an example of how we use AI, because AI, you've got to be careful how you use it, because sometimes people use it as a solve everything. It's got to have a specific problem. So an example is how we use AI to optimize our mechanical thrombectomy pathway. Mechanical thrombectomy is a relatively new treatment in dealing with ischemic stroke. It requires quite a lot of resources, and in this country it's performed by interventional radiologists, and there aren't a lot of them. And so when I was CD, I was asked to help set this up, and I didn't really think I needed AI. I thought, could I just get the on-call neuroradiologist just to read the CT head? That didn't work because people are used to outsourcing it. I couldn't force them to do it in the middle of the night, so that was a no-go. Then I thought, right, could I outsource it to teleradiology? To get a CT head for mechanical thrombectomy done that per hour based upon the actual volume would be about £300,000 a year. I did not have £300,000. Yeah. And then I went, fine, let's go to Brainomics. Once again, there are a lot of issues with it. It is not perfect, but could it do the job I asked of it? Yes. I mean, we did have an award to pay for that, but even if we had to pay for ourselves, I think it'd be about £100,000 a year, and that would do the job. So you're not looking for perfection. You're looking for something that can actually do the job to get you to that end, and that allowed us to establish the mechanical thrombectomy pathway. So that's what AI's use is, really to fill in the gaps. Really,
are there limits to where we could use AI in cancer pathways across the board? Or is it a case that as AI itself develops, that'll take away those limits? If you see what I mean, you said before, Oliver, that AI is the worst it ever will be now, and it's always improving. So, will its range of use and its potential to help us, increase, or is it always going to be, a human element that we need to have and a limit to its use?
I think there will always be a limit to its use. Ultimately, someone has to be responsible, and a machine can't be responsible. It's a medical legal aspect to everything that we do. I do think, having said that the possibilities are enormous, and we're seeing new use cases every day. I think pathways where an example would be areas where there's high manual input and that are just prime for, would benefit from automation. And we call it AI, but a lot of this stuff is just technology that's existed before that's been repackaged. And so AI has become a bit of a buzzword, if you will. But certainly there's huge potential to streamline pathways where there's high volume, low complexity, things that can be automated, and that if it does require a human being to review it, you can build that into the protocol. You can build that into the pathway, if you will.
I agree, and I think it's important for us to be in the space. It's a responsibility, partly to also ensure that the information that is used for the intelligence is actually accurate and best practice.
I also think although there's a lot of potential in AI, remember AI is neither artificial nor is it intelligent, really. You've got to be really careful how you use it, and I think there can be, particularly over the last few years, I've come across quite a few health AI projects which made no sense from an actual workflow because they were developed completely outside the NHS, and you sit down and go like, right, how is this actually either going to make care quicker or cheaper? It may be a nice thing to have, but if it doesn't do a hard thing that I can go to and say to my finance director and say, this is an actual benefit, you can't be too productivity focused on it because sometimes you've got to look at things, but you've got to have a very clear head on what the problem is. This is why I think it's important for people in healthcare to have that look on. And I think a lot of the things they'll help with will be boring things like automation of low stuff like MDTs is a big thing that's draining so many resources, and so MDTs multidisciplinary team meetings, and a lot of it don't belong in an MDT. And yet it takes up so much time of an MDT, which you've got to have oncologists, surgeons, physicians, radiologists, pathologists. It's a huge cost, and a lot of it could be optimized. So boring things like that, that's where I think the future of AI is really going to be massively helpful with.
Do you find, I sort of mentioned it earlier with regard to the chest x-ray thing, but more broadly, do you find any scepticism among colleagues, among maybe older colleagues who are kind of, more traditional in the ways that they want to do things? Do you find any of that when you're trying to bring in, even for the more boring solutions, like you say?
I've had some experience, like with training in AI, that's a big thing. There was one AI that I brought in to looking at intracranial hemorrhage and PEs and all that. And I found that some of the more senior consultants who've been consultants longer than I've actually been a doctor for, they didn't really use it, but some of the admin staff who are, less academic, they'd see the alarm for that this scan had this abnormality and send out for reporting. That wasn't difficult. So I do think there is an issue, and some people if I'm honest, some people simply don't like change because it's not because there's an anti-change or it's just a workflow change. And some people do have a slight fear of automation, although I do think that's been overly hyped up, because you had Jeff Hinton saying in 2015, no point training any more radiologists. We've got consultants who've trained since then. So there's that degree of fear, but that's really more from unknown. But what I found is once people see the benefits of it, like in clinical governance meetings, there was the most recent clinical governance meetings, a lot of the misses we had for like a missed PE, a missed intracranial hemorrhage, they were picked up by an AI and missed by a consultant. Then you start relying on it because you don't want to be the one having missed a disaster, because that's happened. And it's not, I've missed stuff and it's been a disaster. It's not pleasant. It's really not pleasant.
And then you're looking at patients. I sort of mentioned it again, with the chest X-ray, but more broadly, is there a big, communications piece of work to do to educate patients that it is safe, that it is reliable, that if it does get used in more and more and more things, there's no risk, or there's a low risk.
So I think in this case, because we still have a human read, I think it's different in potentially in other areas. For example, in skin AI, where you don't necessarily have a second human read. I think if we piloted that here, we would actually definitely introduce that. That in itself is reassuring. I think where we're sort of working along the whole pathway, particularly if it's a sort of, we found this abnormality on an X-ray, we will fast track a CT. It's ensuring that communication is sort of with the GP, the GP knows about it. So we almost set the expectation for, if you have a chest X-ray, it might be that you get called for a CT scan within 3 days, but that doesn't mean it's something very serious. It just means that we need to do a CT scan to give us more information.
I think because all these AIs that we're talking about still are to use another buzzword, human in the loop AIs. As Andrew said, when you've got more AIs that reduce that, for example, with skin analytics, also you've got the breast AI as well, that can take a second read away. That's an issue. And also when we start developing things that may be involved with decision making, decision optimization, that's something which you're not actually having a human being directly responsible for. But I think and there are issues with patient education, because I found that data education in doctors is quite poor, although it's now a formal part of the foundation you're training. Very few people get properly trained on it. And then by logic, I think there's an issue with that digital exclusion in the patient population, particularly in North East London, which means they should be optimised, because we're not back in the 70s where people would just turn up to the doctor and would have shocking things done to them without, you see women who've had hysterectomies, you ask them, why did you have that done? Doctor told me to. I'm like, you didn't ask any questions? That's still not uncommon. So I think, there are issues about digital education.
The staff training bit is interesting, Oliver, isn't it? Because to bring in all these things and still keep a human element, you're going to have to do a massive piece of work in terms of training your staff.
Yeah, I suppose when we're looking at these tools, and we're not really, there's always a problem that we're trying to solve. So it might be that there's exponential demand for radiology services, or there's already inefficient processes which we're trying to streamline and make quicker. And so the problem is defined. We know what that is, and we're looking for a solution to support that, to make that problem less of a problem, to make the time it takes to get through work less. And so the AI is not there to replace or not there to make someone's life more difficult, although you're right, in the embedding process there is that training which is required. Invariably that's going to take a bit of time.
Because often it's only as good as what you tell it, isn't it?
Yeah,
in lots of ways.
Once it is, the idea is it's there to support, to augment, to upskill, and to give staff the tools to get through their workload quicker and to streamline that process. And so, yes, it's a bit of a commitment in the beginning once it gets embedded, but the long term is that you see an efficiency gain.
I mean, on that point, what Oliver said earlier on about issues with, in some parts, ED had access to chest X-ray AI and had to be stopped because there were issues with overinterpretation. We took that knowledge and we then had we then organised focal online training, an online module with workshops in-house, because I used some previous learning from my other AI projects, showing that you have to really focus on that. Like with my other AI project, the ADOC project we had in BHRUT, 30% used it after 50% used it after 3 months, after 6 months 60%, after 1 year of online and then focused by workshops in hand, they had 90%. So you did a similar mix of that, and after you did all that, I went physically to the AI, the EDs, and the other areas. They were completely fine with it. We've not had a single issue. So it's just about embedding that education and not just launching on people, with particularly things like chest x-rays, because I found that with chest x-rays, doctors will look at and interpret themselves. With things like brain scans, people stay away from that because unless they've had the training, but you've just got to embed that knowledge, that teaching in, so it's not thrown at them.
And I guess as well to you guys probably have emails every day with companies saying we can fix this problem with our new technology, and I guess you've got to have a reasonably cynical mind maybe to kind of pick and choose the right opportunities to use it.
I think this comes to the robust procurement process that was put in place. All the stakeholders from each of the 3 trusts were sort of brought into a meeting, and if you like, there were a pitch from the various companies that were out there. We actually had to repeat the whole process again once we won the AI Diagnostic Fund Award, which led to a little bit of a delay in the implementation, but it ensured a robust process for selection.
I mean, once again, this is why I think it's a good idea. Sometimes people make promises they can't meet, but having spent some time going to Google Health events, I think that's because there's sometimes maybe not enough engagement between the NHS and that project things, and so they're not really aware of what the actual pain points are. So I do think you've got to not necessarily cynical, but you've got to know your brief. You've got to know the process they're involved. For example, like some people were making promises of what the AI can do, which were not supported by current evidence, saying that, if the chest x-ray now was normal, we could then save money immediately by not employing people to do the reef normals, which is, if I'm honest, illegal. And you come across these things, you're like going, yeah, and you're like, so you've got to have people who know the current situation and not have that current level of false promises, or at least uneducated promises. I don't think it's people are necessarily being bad, but it's because they may not understand the full ontology of the process.
But like you say, to understand the problem, like you said, rather than just think AI can fix everything.
Yeah, so I think we were very clear about our case for change. We have a reporting deficit. We have, if you like, AI that can support that triage to make us A, safer, and B, potentially more productive. And I think that the issue about productivity is important because, if you like, we're in pilot funding, and we knew that we needed this for at least 2 years because, to implement this, to get through all our governance processes, to do the procurement, to do the training, and then it's in. And then how do we ensure, appropriate use and the training as we've described. But then the next step for us is actually for this to become, if you like, fully part of our processes so that we, if you like, commission it going on beyond the pilot phase. And I think that's what we're trying to do, sort of hand in glove with the actual process of implementation and evaluation, is ensuring that we demonstrate that value, not only from a safety point of view, but unfortunately we have to do this from a resource point of view and hit that sweet spot that if we can increase productivity by 40% in normal films, that should pay for the software going forwards.
We've sort of touched on it a little bit, but let's kind of wrap this up with a bit of a gaze into the crystal ball. If we were sitting in this room in 10 years' time and we're having this conversation about AI, we've talked about kind of where it might be used, what it might be good for. Where will we be in 10 years' time with AI?
So I think the main role of AI will be to deal with the fact that we do a lot more imaging and a lot more things. Fundamentally, inflation. For example, like if you look at things like prostate cancer, when I was a lad, if someone had an elevated PSA, they'd go, and if they were concerned, then to have something called transrectal ultrasound guided biopsy. Now everyone has a PSA. Now they have an MRI prostate, and there has follow-up scans, and that's now gone from like maybe 8 a week 10 years ago to about maybe 50 a week at least. So AI's gone up, the scan's gone up hugely. And I think what AI will be useful for, we're trying to deal with the more low-risk one. Like the analogies, AI can help looking for a needle in the haystack. One thing it can do, it may not be able to identify the needle to the level we want, but it may be able to remove half the hay. Yeah. So then it makes it easier. I think that's what AI will be very useful for. Just getting rid of the, to get rid of the low-risk things that can allow us to really focus resources. Because we will never have enough resources to deal with it if we continue the way we're doing.
So it should increase safety, as we've described, but by that immediate pre-read, it should increase patient experience.
Because that's the fundamental thing. It has to be for the patients, doesn't it?
And it should support that sort of right test, right treatment, at the right time for the right patient. I think that's what it will help us and allow us to personalise. I think one of the issues that Basab has raised about, digital, the access to digital across North East London, that's something we have to consider. And we have to counter that also with the fact that one of the opportunities that we have is the sort of translation into multiple languages that will support us, the moving from reading to audio. That's also something that will be of a huge benefit where we have problems with literacy.
That's a really interesting point, isn't it? Because we haven't really touched on it. We mentioned it before we started recording, actually, didn't we? The digital literacy, digital poverty across this part of London. We've talked in previous episodes about the diversity in all different ways in this part of London. But that's a really interesting point, isn't it? We can't assume people can use technology.
You go to a lot of these meetings, particularly in central London and run by Google Health, whatever, and you get the uncomfortable feeling a lot of the solutions that they're putting out there are meant for digital natives who are, if I'm honest, middle class with a very good Apple iPhone and all that. But those people aren't the population who are lining the corridors of ED. They're not the diabetic, controlled diabetics or people who've been smoking for ages with COPD who now have weight loss. So you've got to really make sure we're doing the right things for the right person in that framework, and we're not just doing things for the sake of it, because then you've got issues like opportunity loss. And that can have its own cost, because you could have just burnt a huge amount of money on something which looks good, but it's not actually helped anyone. And that's something you've got to doubt yourself to a certain extent a lot, because you can have shiny object syndrome. And that's what I find you've got to be very careful about, and talk to a lot of people from outside the bubble and is it actually useful? You've got to do that a lot, because this is a sexy topic and people can fall in love with it, and you can have the false promise of you can do more for less, which is always something managers love as well. So you've got to be really, really constantly doubt yourself a lot.
This is why evaluations like this are so important, because suppliers, if you let them, will lead you up the garden path with what they can do and what they can deliver, and we need to be sure that what we're doing is relevant, and then it's equitable, and it reaches the population that we serve. So we're looking at other evaluations, but it's the cornerstone of everything that we do.
And we have to learn from that evaluation as well. I think one of the points I made earlier about the sensitivity, we've set it so that it almost overcalls, so that we don't miss lesions. But on the other hand, maybe we'll alter that in the future, because we still have a second human read. Because one of the things of overcalling is that we'll have to monitor this. Would we end up doing more CT scans? Because you can't help there'll be a bias, because you've read in the secondary capture something that suggests there might be something.
And I guess at the start
to Basab's point about perhaps ending up doing more tests.
I guess at the start of all this, we've talked about this a lot of times, particularly when it comes to lung cancer, getting people in the door in the first place, isn't it? We're talking about people here who actually come and say, I've got a cough or something. We need to get people in the door in the first place. And
if I'm honest, that actually might be another future use there, which is what's currently using, like having much more low-dose CTs that can, through AI algorithms, be better. And if I'm honest, that'll probably be replacing chest x-ray in the future, because if you can get that done, what's the point of doing a chest x-ray? So those are things where AI may solve that problem in the future, but you can't base too much of your current decisions on what the future may hold. Otherwise, that's not a sensible way of living. You can't be responsible and do it that way.
And the reason for potentially doing a low-dose CT, which is what we use for lung cancer screening, is that a chest X-ray may miss a lung cancer.
It's such a fascinating topic, and it's
good to listen in 10 years' time to see if the predictions were right.
Isn't it? Because, like you said, you can't actually think like that, can you? Because who would have predicted 10 years ago that we'd be where we are now? So there's no value in really doing that.
But I'd like to say that a lot of the issues I've had with AI are nothing to do with the actual tech bits, like cloud versus local. Like we had an AI that was on the cloud, but because someone did things to the firewall, then it didn't work, and that was an issue. Then we've got things like, procurement. That's actually a big issue, procurement with every trust and own DPI. That's a real issue. if you think big about why a lot of British AI companies aren't scaling up, because it's just insane, and that's something we've got to look at getting better. There's lots of the main issues with AI are fundamentally all structural human things right now: procurement, assessment, and making sure it's working properly. The tech bit, although that sounds most interesting to me, in many ways is not the main issue.
Yeah. Well, it's been really fascinating. Thank you so much to all three of you for taking me through it. It's something that we're all going to have to get used to in every aspect of our lives, isn't it? And thank you so much.
Thank you.
Thank you.